To open this panel organized by ISEC Study Group during the period World Antibiotic Awareness Week with Chair Pınar Sağaroğlu. Our discussion centers on a powerful question: how can education, team dynamics, and laboratory science transform antimicrobial stewardship? We have a distinguished panel of international experts here to explore this very topic. So without further ado, let's begin.
Okay, good morning everybody. Welcome to our session. First of all, I want to introduce my colleague and very private friend, Dr. ONUR KARATUNA. Türkçe mi yapayım, İngilizce mi? Türkçe mi olsun? Türkçe olsun bence. Doçent Doktor Karatuna İstanbul Üniversitesi Cerrahpaşa Tıp Fakültesi'nde tıp eğitimini almış. 2008 yılında Marmara Üniversitesi Tıp Fakültesi Tıbbi Mikrobiyoloji Anabilim dalında uzmanlık eğitimini tamamlamıştır. ...2011 ve 2019 yılları arasında Acıbadem Üniversitesi Tıp Fakültesi Tıbbi Mikrobiyoloji Anabilim dalında görev yapmıştır. 2018 yılından bu yana İsveç, Vaxo şehrindeki Vaxo Hastanesi'nde klinik mikrobiyoloji laboratuvarında çalışmaktadır. UCAS geliştirme laboratuvarlarına aynı zamanda bu laboratuvar ev sahipliği yapmaktadır. 2005 yılından itibaren bakterilerde antibiyotik direnci alanında Avrupa Birliği referans laboratuvar olarak da görevlendirilmiş bulunmakta. Doktor Karatuna'nın laboratuvarı. 2023 yılından itibaren de ADTS standartizasyonu alanında Dünya Sağlık Örgütü İşbirliği Merkezi olarak görev yapan laboratuvarda İşbirliği Merkezi'nin sorumlusu olarak hizmet etmektedir. Sayın Karatuna'yı konuşmasını yapmak üzere zaten kürsüde büyük bir onur, gururla takdim etmek isterim.
Sayın Başkanlar, değerli katılımcılar, herkese günaydın. Öncelikle 8. KLİMUD Bilimsel Komitesi'ne bu toplantıda bana yer verdikleri için teşekkür ederek başlamak istiyorum. Geniş bir konuyu 15 dakika içerisinde özetlemeye çalışacağım. Birazcık koştura koştura gideceğim. Umarım sonuçta tartışmada, soru cevapta aklınızda kalanlara cevap verebilirim. UCAST 2010 yılında ilk klinik sınır değerler sürüm tablosunu yayınladığında sadece 14 mikroorganizma vardı bu tablolarda. Ve yıllar içerisinde bu sayı 37'ye ulaştı. 2025'te yeni bir mikroorganizma eklenmedi. En son 2024'te eklendi. Ve her ne kadar bu sayı 37'ye çıkmış olsa dahi birçok önemli mikroorganizma hala klinik sınır değer tablolarında yer almıyor. Bu UCAST'ın tembelliğinden ya da bu konuyu önemsememesinden değil, bazı mikroorganizmalar için ya da bazı antibiyotikler için veri mevcut değil. Ve bu verinin birikmesi zaman alıyor. Ve 20 sene sonunda hala bazı antibiyotikler ya da bazı mikroorganizmalar için yeterli veri bulunmuyor. UCAST'ın klinik sınır değer belirleyebilmesi için ihtiyaç duyduğu en önemli bilgi mikrobiyolojik ve klinik uyumun gösterilmesi. Yani MIK değerlerinin klinikteki sağ kalımla, tedaviyle uyum göstermesi. Eğer bu veri mevcut değilse UCAST yetersiz veri sebebiyle sınır değerleri belirleyemiyor. Günümüzde laboratuvarlarımızda olaylar genellikle şöyle gelişiyor. Çoğu laboratuvarda artık MALDI-TOF kullanıldığı için çok kolaylıkla nadir rastlanan mikroorganizmaların tanımlamasını yapabiliyoruz. Ve eğer bu mikroorganizmanın enfeksiyona sebep olduğunu düşünüyorsak, genellikle antibiyotik duyarlılık testi yapıp sonuçları da bildirmek istiyoruz. Ama eğer mikroorganizma UCAST sınır değer tablolarında yer almıyorsa, yapılması gereken bazı aşamalar var. Öncelikle bu mikroorganizma için MIK testi yapılabiliyor olması lazım. Bunun için de mikroorganizmanın Müller-Hinton sıvı besiyeri, Müller-Hinton fastidious sıvı besiyeri ya da bir anaerob mikroorganizma ise FAA, fastidious anaerob agarda üreyebilmesi lazım ki agar dilisyon yapılabilsin. Eğer MIK çalışılamıyorsa yapabileceğimiz hiçbir şey yok. UCAST bu konuyla ilgili bir rehber doküman, kılavuz doküman hazırladı ve bu Türkçe'ye çevrildi. Türk Mikrobiyoloji Cemiyeti ADTS sayfasında bulabilirsiniz. Bu UCAST web sayfasının değişen yüzü geçtiğimiz hafta yenilendi. Böyle bir görünüm aldı. Bütün geçmişte hangi dokümanlar mevcutsa şu anda da hepsi mevcut ama birazcık zaman geçirip alışmak gerekiyor. Kılavuz dokümanlar arasından en son sürümü Eylül 2024'te yayınlanmış. Klinik sınır değer tablolarında sınır değerler olmadığında ne yapılmalı dokümanına ulaşıp bu tip mikroorganizmalar için UCAST'ın önerilerini takip edebiliriz. Ama tekrar ediyorum, yapılması gereken şey MIK. Ve MIK dediğimizde aerob mikroorganizmalar için sıvı mikrodilisyonu kastediyoruz. Anaeroblar için ise agar dilisyonu kastediyoruz. Gradyan testler, yarı otomatize antibiyotik duyarlılık test sistemleri ya da disdifüzyon bu amaçla kullanılamıyor. Bilmediğiniz, aşina olmadığınız bir mikroorganizmayı kesinlikle bir yarı otomatize ADT sistemine yüklememenizi öneririm. Çünkü bu mikroorganizmalar üretici tarafından valide edilmiş değil. UCAST'ın bir akış şeması var. Yapılması gerekenleri özetliyor. Zaten ben de sözel olarak bunları şu an özetliyorum. Öncelikle klinik öneminin belirlenmesi gerekiyor mikroorganizmanın. Sonra MIK testini yapacağımız besiyerlerinde üreyebiliyor olduğunu bilmemiz gerekiyor. Ardından bir MIK belirleme testi yapıyoruz. Ve dediğim gibi bu mümkünse sıvı mikrodilüsyon. MIK değerini elde ettikten sonra bu MIK'in ne anlama geldiğini anlamamız için UCAST'ta yer alan MIK dağılımları sayfasına gitmemiz gerekiyor. Ve orada elde ettiğimiz MIK'in ECOF'un üzerinde ya da altında olduğunu görmemiz gerekiyor. MIK ve zon çapı dağılımlarına ve ECOF'lara gösterdiğim link üzerinden ulaşabilirsiniz. Ona tıkladığınızda başka bir sayfaya ulaşıyorsunuz ve buradan arama yapabiliyorsunuz. Örneğin burada ben Enterococcus hierae için bir arama yaptığımda çeşitli antibiyotikler için dağılımlar olduğunu görüyorum. Örneğin siz tetrasiklin için MIK testi yaptıysanız burada Enterococcus hierae'nin tetrasiklin ECOF değerinin 4 olduğunu görüyorsunuz. Bu bilgi klinik sınır değer tablolarında yer almıyor. Ama UCAST'ın bu MIK dağılımları sitesinde çok fazla sayıda mikroorganizma ve antibiyotik için bu tip dağılımları ve ECOF değerlerini bulabilirsiniz. Bunu ECOF değerini gördükten sonra son aşamaya geçiyorsunuz ve bu MIK'in ne anlama geldiğini, tedavi edilebilir mi, tedavi edilemez mi olduğunu görmek için gene aynı kılavuz dokümanda mevcut 2 tane tablodan faydalanıyoruz. Bir tanesi aerob mikroorganizmalar için, sol sütunda gram pozitif organizmalar için MIK değerleri listeleniyor, sağ tarafta da gram negatifler için. Bu MIK değerleri tedavi edilebilir en yüksek MIK değerini belirtiyor. Örneğin ben buradan bir örnek vereyim. Meropenem için gram negatiflerde 2 veriliyor. Bu ECOF'un altında olsun ya da olmasın bir MIK değeri eğer 2'nin üzerindeyse bu meropenemle tedavi edilmemesi gerektiği anlamına geliyor. Bir mikroorganizma meropenem için sokak tipi olabilir ve örneğin ECOF'u 4 ise ECOF 4 olduğunda 4 ve altındaki MIK değerleri sokak tipi izolatları işaret ediyor. Ama burada meropenem tedavi edilebilir değer 2 gösterildiği için eğer elde ettiğiniz MİK 4 ise bu meropenemle tedavi şansının olmayacağı anlamına geliyor. Ve benzer bir tabloda anaerob mikroorganizmalar için var. Bütün bu testleri yaptıktan ve tabloda değerlendirdikten sonra sonuçlar nasıl rapor edilmeli, bildirilmeli? Eğer o antibiyotiğin kullanılmasını istemiyorsanız, klinisyenin kullanmamasını sağlamak istiyorsanız dirençli olarak bildirime izin veriliyor. Fakat S veya I kategorilerinden kaçınmak gerekiyor. Bunun yerine elde ettiğiniz MİK değerinin tedavi edilebilir sınırlar arasında olduğunu belirtebilirsiniz. Ama S veya I harflerini kullanmaktan kaçınmak gerekiyor. Çünkü bunların her ikisi de duyarlı anlamına geliyor. Fakat biz aslında burada duyarlılıktan emin değiliz. Biz sadece suşun, izolatın sokak tipi olduğunu biliyoruz. Tedavi edilebilir MİK sınırları arasında olduğunu biliyoruz. Ama UKAS tarafından tanımlanmış klinik sınır değer olmadığı için bu S ve I kategorilerinden kaçınmamız gerekiyor. 2 tane örnek vererek sunumumu tamamlayacağım. Bunları uygulamalı olarak göstermeye çalışacağım. Birinci örnek Stenotrophmonas maltophilia. Laboratuvar trimetoprim sülfametoksozoil için zon çapı belirlemiş 25 mm ve de mevcut klinik sınır değerler ışığında bu I olarak belirtiliyor. Yani duyarlı ama artmış yüksek dozla. Dozajın arttırılması gerekiyor. Zaten trimsülfada S seçeneği yok. Mutlaka yüksek doz kullanılması gerekiyor. Fakat klinisyen laboratuvardan trimsülfanın yanında ceftazidin ve levofloxacin duyarlılıklarını da istiyor. Ne yapalım? Bu 2025 tablosu Stenotrophmonas maltophilia için. Önce isterseniz levofloxacinle başlayalım. Levofloxacin'de bir not var. Ve notta diyor ki tedavide kullanılabilir ve ECOF burada yararlı olabilir. O zaman levofloxacin için MİK belirleyelim. Laboratuvarın bu kapasitesi mevcut ve MİK'i belirlediğinde 4 mg olarak buluyor. Peki bu tedavi edilebilir mi, edilemez mi? Stenotrophmonas sokak tipi mi, sokak tipi değil mi? Onun için ECOF'una bakmamız lazım. Demin gösterdiğim siteden MİK dağılımlarına gidiyoruz. Ve sokak tipi suçların, Stenotrophmonas maltophilia'nın levofloxacin MİK değerinin 4'e kadar olduğunu görüyoruz. Bu bize bu suçta levofloxacin için kazanılmış bir direnç olmadığını gösteriyor. Ve sokak tipi bir suç. Ama sokak tipi olmak tedavi edilebilir anlamına gelmiyor. Bunun için de tekrar o tabloya gitmemiz lazım. Bu dağılımla sadece suçumuzun sokak tipi olduğunu belirliyoruz. Tedavi edilebilir ya da edilemez olduğunu görmek için tabloya gidiyoruz ve levofloxacin için tedavi edilebilir MİK değeri gram negatiflerde 0,5. 4, 0,5'in üzerinde olduğu için levofloxacinle tedavinin uygun olmadığı sonucuna varabiliyoruz. İkinci antibiyotik ceftazidimdi. Ceftazidim için UKAS ne diyor? En yukarıdaki satır. Gördüğünüz gibi tire işareti var. Yani test etmene, herhangi bir test yapmana gerek yok. Bunu dirençli bildirebilirsin anlamına geliyor. Ama eminim ki içinizden bazıları CLSI'da ceftazidim var, o zaman gideyim ona bakayım diye düşünüyor olabilir. Aslında CLSI ve UKAS uzun yıllardır birlikte çok yakın çalışıyorlar. Bu CLSI'ın bir yayını ve kendileri diyorlar ki biz Stenotrophmonas maltophilia için klinik sınır değerleri belirlediğimizde sadece 10 tane izolat test etmiştik. Ve bu 10 izolata dayanarak klinik sınır değerleri belirlemiştik. Sağ üst taraftaki tabloda da görüyorsunuz aslında disdifüzyon sadece trimsülfa için çalışıyor. Diğer antibiyotiklerde özellikle ceftazidimde tekrarlanabilirliği çok düşük. 76 %76. UCAST yıllardır trimsülfada inat ediyor. Disdifüzyon sadece trimsülfaya çalışılabilir diyor. Ve en sonunda CLSI'da gördüğünüz gibi ceftazidimi listesinden çıkardı. Ve bu 2024'te gerçekleşti. CLSI'nin sınır değer değişiklikleri tablosuna bakarsanız ceftazidim, MIK sınır değerleri Stenotrophomonas maltophila'dan çıktı. Artık ne MIK ne de disdifüzyon, zaten disdifüzyon yoktu. MIK sınır değerleri de Stenotrophomonas maltophila'da bulunmuyor. Çünkü onlar da ceftazidimin uygun bir antibiyotik olmadığını görmüş oldular. İkinci örneğim Burkholderia cepacia kompleks için olacak. Dün kapsamlıca tartışılmış. Ben ne yazık ki bir toplantıya katıldığım için bu güzel toplantıyı kaçırdım. Tam ne tartışıldığını bilmiyorum. Umarım benzer mesajlar veririz. Burkholderia cepacia'da ne yapalım? Gelmeden önce İsveç'teki enfeksiyonculara uğradım. Hemen gelmeden bir gün önce. Dedim ki böyle bir sunum yapacağım, siz ne yapıyorsunuz? Bizde Burkholderia yok dediler. Hiç konuşamadım, bu kadar. Burkholderia, Stenotrophomonas maltophilia, bunlar yok. Yani ne yapacaklarını bile bilmiyorlar çünkü yok. Onun üzerine ben literatür taradım. Bu 2013'ten UCAST'ın kılavuz dokümanı. Sonuçta ben burayı özetledim ama deniyor ki mümkünse antibiyotik duyarlılık testi yapma. Çünkü MIK değerleriyle klinik sağ kalım arasında herhangi bir ilişki gösteremiyoruz. Burkholderia enfeksiyonları genellikle mix enfeksiyonlar. Verdiğimiz antibiyotik neye etki ediyor onu ölçemiyoruz. Artı genellikle kombine tedavi yapılıyor. Gene tek bir antibiyotiğin etkisini göremiyoruz. Elimizde veri yok. Ama sıvı mikrodilüsyon testi güvenilir bir yöntem diyorlar. Bu şu an UCAST'ın bilimsel sekreterliğini yapan Mandy Wotton'ın çalışması ve gösterdiler ki gerçekten sıvı mikrodilüsyon yaptıklarında tekrar edilebilirlik çok düşük. En yüksek minosiklinde görüyorum 84,5'la. Meropenem'de %70. Yani birazcık ne diyeyim zar atmak desem bilimsel olur mu? Zar atmaya benziyor. Ya da yazı tura diyeyim daha bilimsel olsun. Daha istatistiksel. Yazı turaya benziyor. Sürem bitti, bitirmek üzereyim. CLSI Burkholderia için ne diyor? Önce 2024'te disdifüzyon sınır değerlerini tablolarından çıkardılar. 2025'te MIK sınır değerlerini çıkardılar ve gördüğünüz gibi artık CLSI'da Burkholderia için hiçbir şey önermiyor. Diyorlar ki epidemiyolojik cutoff'ları yani epidemiyolojik eşik değerleri belirledik. Çok yüksek sınır değerler bunlar. O demin gösterdiğim UCAST'taki tedavi edilebilir en yüksek MIK sınır değerlerini de yanına koyduğumda aslında bu ECOF'ların çok bir işe yaramayacağını göreceğiz. Yani ceftazidim diyelim 16 ölçtünüz, sokak tipi ama gene tedavi edilemez olacak. Sonuçta ve bütün bu ECOF'ları da şu yaptıkları çalışmaya dayandırıyorlar. 205 tane izolatı test etmişler, kistik fibroz ve kistik fibroz olmayan. Sadece sıvı mikrodilüsyon güvenilir içlerinde, disdifüzyon, agar dilüsyon, gradient difüzyon hiç güvenilir değil, sakın çalışmayın diyorlar. Ve özet olarak diyorlar ki, Burkholderia için rutin antibiyotik duyarlılık testi çalışılmaması öneriliyor. Eğer çalışacaksanız sıvı mikrodilüsyon çalışın ve de S, I, R kategorilerini kullanmayın. Sadece MIK'i bildirin ve bu MIK'i klinisyenin değerlendirmesine bırakın. Sabrınız ve sabahın bu erken saatinde burada olduğunuz için çok teşekkürler.
Sayın Karatuna'ya çok teşekkür ediyoruz. Zaman sorunumuz yüzünden şimdilik soru almayalım. Sunumun sonunda inşallah almayı umut ediyoruz.
Teşekkürler Onur. I would like to introduce you next speaker Sophie Schneitler from Germany. She is a specialist in internal medicine, gastroenterology, microbiology, virology, and infectious disease epidemiology. She holds the Master of Science in Public Health from London School of Hygiene and Tropical Medicine and has additional training in tropical medicine and infectious diseases. Her education took place at the universities of Düsseldorf, Leipzig, and Saarland in Germany. During her international training, she has been to Peru, Thailand, and various countries on the African continent, both for training and in the area of capacity building. She currently works as a senior physician at the University Medical Center, University of Cologne. She has the outpatient department for travel and tropical medicine and the laboratory departments for parasitology and serology. Her main focus is on the diagnosis and treatment of infectious diseases. Her research focuses on infectious disease diagnostics, particularly in the area of diagnostic stewardship and issues relevant to travel and tropical medicine. In addition to her clinical work and research, she is involved in teaching and training students and young physicians. As part of this work, she is also active in various professional associations, including the German Society for Tropical Medicine, Travel Medicine, and Global Health, and JUNIT, a German network for young doctors and researchers. Thank you. Please.
Thank you very much for this kind introduction. I'm happy to be here, and I'm really sorry I can't speak Turkish, so I have to do it in English. There are no conflict of interest related to this topic, and let's start. I think at first, if we discuss medical education in antimicrobial and diagnostic stewardship, we have to see which kind of teams are involved, means which specific groups. And we see here on the screen at first the antimicrobial stewardship team. It's quite huge with clinical microbiologists, infectious disease specialists. This is sure the core team. But at the end, you have to include nurses, IPC, data specialists, hospital administration, and much more. If we are looking in the group of diagnostic stewardship, we have to discuss which groups are here included also. So at first point, it's the AMS team, but it's also the lab technicians, the clinical doctors of all departments, the physician assistants, phlebotomists, and staff in education and medical students. So you see, here's the group much more. And we have to ask ourselves, in all of these groups, do we miss somebody? And this is often forgotten if we discuss medical education, that there is a huge group we have to include in all our decisions of diagnostic stewardship. This is the group of patients. And this is quite a bit complicated to educate, but we have to educate them because often they are the start of our samples. So, at first, let us look back a bit. What is the definition of medical education? It is a process of training future healthcare professionals and continuing the professional development of current practitioners. This encompasses a wide range of activity from undergraduate medical students to the postgraduates. And continuing medical education, we know all of us to do it, and to do staff training within the healthcare system. I'm a bit sorry for the slides. I think there is a problem with the computer and the letters, but okay. As I saw it for a few minutes, it looks quite nicer, but at the end, it's the content. So why we should care for medical education? Because this is the transformation of knowledge, skills, and attitudes and behaviors, and that's the reason why we need this for the best patient care. There are some different learning models, and I like to introduce, from my perspective, a really easy one. And you see here that there are 4 different types of learners. It's called VAG model, means that there are visual learners, auditory learners, and kinesthetic learners, and read and write learners. So most people will explain, okay, I'm more a visual learner, or as an example, I like to listen to something like a podcast or something like this. If this is really true, is quite a question of research. ongoing research if it is really a typical learner type or not. But what we know of certain is that there are some preferences in learning, and we have to respect, and that it's difficult to include all of this in a typical hospital setting also. So we have to ask ourselves, how does medical education work in everyday hospital right now? How we educate our staff? And let's step back a bit in a typical clinical situation in Germany. There is a junior doctor and a patient, and the patient said, oh, I have fever. The nurse said I should ask for some blood culture testing. And the junior doctor is thinking, okay, I had never done this before. Which person should I ask to do this task and to teach me to take in a proper way blood culture diagnostics? And what's the patient thinking? In the most way, they know, okay, this is a junior doctor, and maybe she can't do this task in a proper way. So we have to reflect that medical education in hospitals often works with according traditional knowledge to transfer traditional knowledge to the next team. And in my situation, as I started my clinical career, I had not learned to draw blood culture diagnostics from a doctor, from a nurse. And nurses are not trained in Germany to take blood culture diagnostics. So in my first year, I think there were quite misunderstandings in case of blood culture diagnostics. And we have to reflect also that this traditional knowledge and behavior is regarding quality and quantity, depending on the expertise, quite totally different in our staff. And so we have to ask ourselves, is this the best training we can offer? And is there anything we need to consider as learning models to reflect these topics? And maybe if all the really basic stuff is included in our medical university studies. I'm more a diagnostic stewardship people as an antimicrobial stewardship people, but I think both is quite important. At the end, I believe that diagnostic stewardship is a bit more important because it's a basic for really good antimicrobial therapy. If the diagnostic stewardship area means the diagnostic testing is not really done with a good sample and a proper testing, the therapy will miss the goal. So we have to look in optimal antibiotic stewardship. And I like to introduce some data we collected with a network of young infectious disease specialists in Germany. And this is done in different health groups, means there were people from human medicine included, but also from veterinary medicine and nursing staff and medical assistants. Just as a short explanation, the blue line is the medical doctor, the green line is a veterinarian, the veterinarian team, the gray line may be a bit difficult to see is nursing, and yellow is medical assistants. And what you see is which kind of information is available at the time of sampling, and you see that for veterinarians in Germany, it's quite easier to know what will this test cost in our health system, and what is the optimal container to send a sample, what is the optimal transport mode to send the sample, and which kind of minimum quantity I need for this test. So it is for them quite easier to do diagnostics as for human medicine in Germany. The next question is this information required at the time of sampling? And you see that all groups are interested to know how to do a test in a proper way, but they haven't in reality. And if we go in the clinical area, we see that the average time to process microbiological diagnostics in these different groups is quite huge per a normal working day. In human medicine, it's in some 40 minutes per day. They are looking for any kind of diagnostics in microbiology diagnostics. Veterinarian needs some time more for this, but you have to reflect that often in hospitals, nursing assist or medical assistant assists this procedure. So at the end, there are quite a lot of time of the day is used for microbiological diagnostics in hospitals, and this is an economic area also. And if we are going now on the other side, on the side of the lab people, means our side, you see here the proportion of incorrectly submitted samples. And in human medicine, you see that quite a lot of the samples is not correct submitted. So there is a problem that you have to reflect how often you have a sample which requires, as an example, consultation. And you see that this is quite often in human medicine also. Up to 20% in the most cases, they say, okay, if there is a sample, I have to ask the ward nurse, I have to ask the doctor what I should do and in which area we got this sample. And we have to ask also how many times we can't do proper analysis because this quality is insufficient. Luckily, it's not so often. It's up to 15% in the main time. But if you are looking that sometimes it's an invasive sample, I believe that 15% is quite too much because it is a delay in our diagnostics, and the delay in microbiology is at the end a delay in therapy. So if I invite you to do some medical education in this area, we have to concentrate at first. Do not start with 100 different projects. Start with one topic. As an example, blood cultures, urine cultures, respiratory cultures, and Clostridium difficile as an example. I prefer in the most ways blood cultures and urine cultures, but all of them are quite good topics to start in a proper way. And you have to reflect again that in all areas in which many people in the sample collection are involved, include the patients also, because in all these areas you need the patients. So check it first for your project if you included all the parties that are involved in your team. And from my experience in each hospital, it's quite totally different which parties are involved in this area, and you have to discuss this in depth with the staff of the ward or in the outpatient clinic, and to look how to include all of them. You need a kind of information to technology and the hospital leadership, because without hospital leadership support, often you fail with your project. And include the patients in case there is a need. And decide what is the main problem in this blood culture diagnostics as an example, or look how I can see what is my main problem here, and define this goal for your work. Ensure that there is the support of unit and hospital leadership as discussed, and track if you fulfill your goals or not. Here are some different examples, what you can do to do better diagnostic stewardship. And one of the easiest thing is to selective reporting antimicrobial test results, so that a clinician is not aware that there are more to use, or do some selective testing also. But you have to attract people to do medical education. So let me introduce one step in this quite normal circle of a sample. It's the provide nudges. What's nudging? Nudging is from a Swedish area, and it's that you are concentrated on one point. And it's built up by the problem that there was quite a huge spillage in toilet rooms, and you see a fly in this toilet, and after they did this, you have a reduction of 80% of spillage in this area. But it's not only possible with flies, it's possible with other devices also. And from my perspective, I think it's funny, but it's depending on culture, I believe so. So this is quite the next step we have to look in medical education. What encourages learning? And there is a self-determination theory, and this includes the intrinsic motivation and well-being. And you have to see that you need autonomy, competence, and connectedness to the topic. This needs the people to be attracted to be part of the better diagnostic of your project and so on. So this will satisfy the people and the learning context, and you will increase the motivation to be part of this thing. So the joy of learning must be increased at the end. Let me shortly introduce the Choosing Wisely campaign, what we choose as an example to as a kind of project to increase the knowledge of the topic that asymptomatic bacteriuria is not a thing you have to treat, because often if a clinician see, okay, there are some bacteria, I have to treat it in urine, that's not true. So there are different styles we used to attract our people to do it in a better way. You see, it's more a comic style, or it is more cultural way, between a discussion between devil and an angel. There are quite totally different ways how to attract people. Or you can do it in the same way as Tapas Mukherjee. He is a pulmonologist, totally different from our field. But as he started a rotation in a hospital, he saw that the people do not following the national guidelines for asthma. And so he started this video, and you can scan this QR code and see it later. Because of the time, it's not possible to do it now. And he introduced this in the hospital and increased quite high the numbers of staff using these guidelines after this video. And it is possible also to engage patients with this topic. As an example here, how to use in a proper way the inhalers. It's quite interesting what people do, or patients do this daily with inhalers. So 80% of the patients do not know how to do it correct. And it's the same with urine and with our sputum samples and so on. So we have to do something to attract the people. And if we are looking in the area of gamification, it's more and more famous in medical education. You can do medical Jeopardy, you can do Kahoot teams, and other things like active case studies, flashcards, or virtual reality, or like escape rooms to train the people to do better diagnostic and antimicrobial stewardship. And let me do 1 or 2 slides for blood culture, because this is quite an important topic for us also. You have to see which person decides the medium. And this is one of the steps we can't change. If the wrong medium is used for a blood culture, we can't change anything in the lab. And you have to see that 16% of blood cultures are not optimal filled for our goal. So we ask our staff in emergency room and intensive care, when are blood cultures taken? And this is a multiple select question, and you see 3 different groups: physician, nurses, and other. And you see the first column is before the people are trained, then after they refreshed the knowledge, and then 3 months later, again with the same question. And you see that they did it quite good after the training, with some mistakes in the group of nurses. But I like to reflect that 3 months later, the nurses has missed the most of the knowledge. Why? Because blood culture diagnostics is not included of the normal training in nurses in Germany. So this training was the first time they have heard anything about blood culture diagnostics. And what you have to reflect in medical education is you have to repeat the interventions and to tailor this to the need of the people. So you have to address it different in nurses, and you have to repeat in nurses quite more often. So from my perspective, if you are looking at medical education, I believe that the first point, improving knowledge and decreasing cognitive bias, is one of the most important parts to do better diagnostics and stewardship topics. But there's always the need to know the regional resistance patterns also beside of all these things. And beside of this, I have to discuss that there's also the need to know the diagnostic possibilities in your region and the used tools and materials, because this will change the habit also, and re-evaluate if there is something different. As an example, as I started my blood culture work, they changed in the project the blood culture bottles to glass bottles, and the behavior was changed also. So these are quite necessary to re-evaluate. If you start the finalizing, stop overcomplicating things. To do some medical education projects is at the end quite really easy. Implement medical education in your daily life as an ID or CM specialist. Each phone call is a possibility to change the behavior of the clinicians.
Sorry, could you please?
Yeah. Analyze local situations, do qualitative interviews to start your project. start it simple, take on fun, effects, and repeat. And do not believe that medical education is in one room. Medical education is a lifelong process. Starts with a baby as a student and a postgraduate. But if you do it in an early stage, you need a bit of water to increase the plant. And how older you are, you need more and more water to increase and have a better knowledge. So start at an early age and think on the area where hard to reach and do some qualitative area also. Thank you very much for your attention. Çok teşekkür ederim.
Thank you, Sophie. Because of time limitation, we couldn't accept questions. Sophie is here today. If you would like to ask her in person, you can reach us. Thank you.
Our next speaker is not in hall now, but she will talk by online. Let's warm welcome to ESMİTA CHARANI from South Africa. She is ESMİTA is an associate professor of Cape Town University, and he write to me, and she said me, just say, I'm a pharmacist by training and now researcher who loves Turkey and speaks a bit of Turkish, but has to give talk English. Very sorry. Let's.
Hello, hi. My name is ESMİTA CHARANI, and I'm going to be presenting some research that we are involved with that focuses on understanding culture and team dynamics in antimicrobial stewardship. I'm very grateful to KLİMUD, particularly to Dr. Osman for inviting me to speak at this meeting in Antalya. I'm very sorry I'm not there in person. Currently, my team and I are on a research visit not far away from Turkey and India, but it was very difficult to be able to find the right connections to make it to both places at close to each other times. So my background is that I'm a pharmacist by training, and I have been conducting research in antibiotic stewardship for the last 15 years, specifically looking at how we change behaviors of individuals. I started this work in the UK, but we've been working increasingly in South Africa and India, and moving away from secondary, tertiary care into community practices as well, to look at stewardship from a holistic perspective. We've just published with colleagues in Australia a comprehensive overview of antimicrobial stewardship from a One Health perspective. And I'm aware I'm speaking to a very knowledgeable audience when it comes to stewardship. We all are aware of the central pillars of effective stewardship, which includes policy and political economy, so operationalizing national action plans, recognizing at-risk populations within countries, and ensuring that there is targeted interventions for different populations, whether it's within surgery, in the elderly, those who are socioeconomically challenged, and other specialties, and also primary and secondary care. And then from healthcare workforce dynamics, stewardship has to involve recognition of the wider healthcare workforce and the roles that they play. This includes pharmacists and nurses, and in different contexts, it's different healthcare professionals who are allowed to have a space and a role in stewardship. So in the UK, in Australia, in the US, pharmacists are increasingly involved. I don't know to what extent pharmacists are involved in the Turkish setting. In Turkey, I know microbiologists are clearly involved, and this is a microbiology meeting that we're attending right now. But it's really important to recognize how we can work together across different disciplines to ensure that we implement stewardship effectively for the best outcomes for the patient. And this also includes working with the laboratory, clinical laboratory. We did a piece of research with colleagues in Norway that illustrated, even in an advanced healthcare system as exists in the Norwegian model, there were fragmented relationship between the clinical microbiology and hospital clinicians to be able to effectively use diagnostics when they are needed most appropriately, laboratory diagnostics. And so I think these are challenges that we face regardless of the setting we're in. And then the work that I'm involved with is looking at an intersectional lens to equity and access into stewardship interventions. So looking at how our identities based on race, ethnicity, class, education, migration status, and other social factors influences our access to antibiotics, and how we actually also work together in teams, and I'll talk a little bit about that. How our layered identities influence the level of power we have in decision-making in the hospital setting, and how that might influence antibiotic stewardship. And then lastly, but not least, it's also about the living and work environment, ensuring that in many different parts of the world, stewardship is implemented very differently and at different levels of maturity. So in countries where there is universal health coverage, where there is adequate access to water, hygiene and sanitation and vaccination programs, and where people do have access to robust primary and secondary care healthcare services, stewardship can be implemented more cohesively. But in countries where there is still a lot of inequity in terms of access to healthcare, and the population needs differ, and the hierarchy of needs in relation to health are different, stewardship is not implemented as easily. And also it may not be the first priority, because within the broader picture of managing the threat of antibiotic resistance, the pillars of access to clean water and sanitation, access to vaccination programs and infection prevention still need to be addressed in many parts of the world. And then when we look at the data around stewardship, when I was a pharmacist, I used to collect data for antibiotic stewardship in hospitals in the UK. We had many challenges in being able to evaluate the quality of the antibiotics that were being prescribed. Even in the UK, where we had electronic prescribing system by the time I finished working there as a pharmacist. And we thought this would solve a lot of our problems, but of course it had issues of its own. And then when we look nationally at the data that is reported, it's not mandated, but it is recommended that countries report data to different databases for AMR surveillance, and these include GLASS, which is a WHO repository, Atlas, which was originally a collaboration between Pfizer and Wellcome Trust, and ECDC, which is predominantly for Europe, and I think Turkey reports to that. We looked at the differences in susceptibility being reported for E. coli, for Staph aureus pathogen to these databases for the same year for the same country, and we saw quite a big variance. So for example, this particular one this country is reporting 56.6% susceptibility to Staph aureus to GLASS and 37.6% to ECDC for the same year. So regardless of where we're working, we need better data, and we need reliable data in relation to reporting antibiotic surveillance, antibiotic resistance patterns, but also antibiotic consumption, which is even more challenging to get data from. And there are big variations in terms of countries at how we use antibiotics and the level of antibiotic that we use in different parts of the world and access to antibiotics. So we do need to improve surveillance. We do need to be able to report more consistently national, but also regional data on antimicrobial stewardship, on antibiotic resistance, to be able to support antibiotic stewardship programs. Some of my early research was specifically speaking to the title of this talk that I'm giving, which was about understanding the culture of team dynamics in hospital settings. And for my PhD, we really looked into this in detail in hospital settings in the UK, in India, in Norway, France, Burkina Faso, and we chose these different countries because we wanted to look at different healthcare economies where antibiotic stewardship was being administered or implemented at different levels of maturity. And what we described was that there is a culture of antibiotic prescribing within hospital settings that is not recognized or accounted for in policy and guidelines. And this is very much around clinician autonomy and seniority, deciding the choices that we make for antibiotic use and when to start antibiotics, what antibiotics to use and when to stop. And often this goes counter to the norms that we expect with policy and guidelines. So we talked about prescribing etiquette and this sort of social norms that decide prescribing behaviors. And then we collected quantitative data from surgical and medical teams to be able to differentiate, because Often in antibiotic stewardship interventions, we target medical specialties because we see them as a low-hanging fruit, and we avoid surgical specialties because we think they're difficult to engage with, because we think they just prescribe cephalosporin and metronidazole. So we collected data to see how true this was from the hospital in the UK, and we actually described that these patterns that we assume about differences in antibiotic prescribing are not true. Patients who are in surgery actually are prescribed antibiotics more frequently, for longer, and the antibiotics are more likely to be escalated and less likely to be compliant with policy, with local policy. Now, there are a lot of reasons for this, but the main reasons are around the risk aversion practices that surgeons have, the culture of blame, and the need to protect and to prevent a negative or unintended consequence for patients under their care, and this fear of sepsis that is very prominent in surgical patients. Everything becomes sepsis, and it's something that the surgeons respond to by prescribing broad-spectrum antibiotics. But I just want to remind ourselves, so that's in a high-income setting where we do implement antibiotic stewardship interventions and we have policy and guidelines. In many other parts of the world, before we think about stewardship, we have to think more broadly, as I mentioned, looking at other needs within the healthcare system that need to be addressed, and this is water, hygiene, sanitation, infection prevention, and vaccination. We repeated our study in South Africa and India, specifically targeting surgical populations to see how we can improve practices. And one of the things we noticed was the culture of practice was very similar. Regardless of where we are practicing, the surgical teams have a tendency to be more cautious and more fearful of negative or unintended consequences for their patient groups, and they will behave or respond to this by prescribing antibiotics using more broad-spectrum antibiotics for longer. This was a patient in India who was a 44-year-old female who was in hospital for 42 days for surgery. And for the majority of the time she was in surgery, in green, she was on broad-spectrum antibiotics, guided by many different culture and sensitivity results that were sent to the laboratory, but often these results were not accurate because they had been taken without the aseptic technique, for example, or the cultures were taken by staff who were not adequately trained. It may have been a contamination, it may have been a colonization. So once we start antibiotics for patients in the hospital setting and then we do testing, it becomes very difficult. But one of the things that stood out was the number of people who were involved in the care of one patient. 84 members of staff had a role in antibiotic decision-making. So it's a very broad group of healthcare professionals that are involved in decision-making that we need to target when we look at behaviors. We repeated this in neonatal surgery and ICU in the hospital in India, and again the surgeons were telling us the same things that the surgeons were telling me in the UK, that it's the fear of sepsis, it's the complexity of surgery, and prior antibiotic exposure that they're concerned about in the community. And that brings us to what I was saying about access, that in many different parts of the world, it's also the access to antibiotics that may decide the outcome of infections for patients. And it's something we need to consider is has the patient been exposed to antibiotics or resistant pathogens in the community, in the environment in which they live. We also did a study with my colleague Candice Bonaconza, whose picture is at the top here, and my face is blocking her. So she is a nurse, and we looked at the culture of decision-making around the patient bedside. And what we described, this is in surgical patients in the ICU, in general surgical units and cardiovascular units. And what we found is that, so this is all the interactions, this sociogram shows who's speaking to whom about what. So the inner circle is who initiates conversations, who they speak with, the second circle, and outer circle, what they talk about. We found often the conversation around the patient bedside on ward rounds is between the consultant and the registrar. This very thin grey line is how much nurses and patients were involved in care of in discussions around patient care. Although infection-related topics did come up in the ward round and the decisions were made, it was often very ambiguous because the nurses weren't drawn in. And some of the tasks were for nurses, for example, taking bloods, removing lines, inserting lines, or giving antibiotics on time. Opportunities for effective stewardship was missed, and this is something that is really important to bear in mind. So Candice then followed this work by conducting, as part of her PhD actually, and did a whole series of studies looking at how do we bring nursing into stewardship programs, and she developed a tool for handover for nurses to be able to include effective stewardship and infection prevention actions within the nursing handover, and she was able to show how you can effectively bring in a wider healthcare workforce into decision-making around antibiotic stewardship. So we also worked, I want to show this slide, and this is going to be my end slide, is to look at how we can deliver things at scale. So this is a study that was led by Dr. Dina van den Berg at South Africa in neonatal ICU, where she engaged with, across 14 hospitals, 7 private, 7 public, in South Africa to initiate 12 hospitals, sorry, 6 private, 6 public hospitals, to initiate a team-led neonatal ICU intervention around improving antibiotic use. And this was led by the nurses and the doctors locally through conversations, through team negotiation and discussions around stewardship. They were able to demonstrate over time decrease in inappropriate antibiotic use. So we can deliver interventions at scale, but I think it's really important that we break some of the hierarchies that exist and we work with different healthcare professionals. I'm going to stop talking here because I have spoken for 14 minutes. I had some data to show around access to antibiotics in different settings, but I think what I want to end with is to realize a lot of the decision-making around antibiotic exposure, antibiotic use, and AMR exposure happens in the environment in which we live on a daily basis, and our access to antibiotics, a lot of it occurs in the community, and that's something we should bear in mind. We focus a lot on stewardship in the secondary care or tertiary care, but a lot of the health decisions and health outcomes are actually decided in primary care and in the community. And this is from our visit here in India at the moment where we went to a lot of pharmacies and quasi-pharmacies that were dispensing antibiotics without prescription. In many parts of the world, this is still something that we need to negotiate and understand better. How do we improve access to effective healthcare for people around the world as part of good stewardship? And I'm going to end there on 15 minutes. Thank you so much for listening. I'm very sorry I'm not there in person, but I am online for any questions. Thank you very much. Bye.
Thank you very much, ESMİTA. Now she is online. If there is any question, we will take first for her, and if there is no, for Sophie. Please, Sophie.
ESMİTA, just a question. If we see the behavior of the surgeons, I believe that's totally true. And I ask myself, maybe it would be good if they have a kind of an internal medicine assistance, mean that there's always somebody who do all this task for what's not surgery from another discipline in this area. Do you believe that this will be increase the behavior of the surgeons?
Hi, Sophie, and hello, everybody in the room. It's a really good question. So when I was doing this study in the UK for my PhD that I presented, the hospital recognized this need for this, and they provided a medical clinician, a medically trained from medicine, not surgery, to once a week review all the surgical patients and see to their medical needs, not their surgical needs. It was mixed in terms of response, because there is still that issue of if the antibiotic has been prescribed for a surgical outcome, for example, surgical site infection or surgical wound or ASA, because often in surgery also, surgical teams use antibiotics, particularly in acute surgery, as an intervention instead of surgery. So if someone comes in with acute appendicitis or cholecystitis, sometimes antibiotics is an intervention that surgeons use. But there was, again, this issue of who oversteps who in decision making, and ultimately the final decision is with the surgeons because the patients are under their care. So I think whilst it is good to have these intercollaborative sort of deliberations about looking after the patient, but we also need to engage with the surgeons themselves about better use of antibiotics and about their risk perception around antibiotic use for surgical patients, which is very different to the risk perception about antibiotic use in patients who are under medical care.
Thank you very much. One more question, please, Dr. Esra.
Thank you very much for both speeches. I ask my question to both of the speakers, also for Sophie. You talk about a huge team, including patients, medical students, nurses, pharmacists. I want to ask about your opinion for how do you start this? I mean, how do you engage these people into the team when you start these activities? Because you talk about very different professions, very different level of knowledge. We even cannot explain ourselves to surgeons or ICU doctors or anesthesiologists or any of them. So how do you start? I mean, how do you start and proceed, and how do you make it a team? It seems very impossible to me. So I want to listen to your opinions about where to start or how to proceed. How do you make a homogeneous team or things like this?
You first.
So thank you very much for this question. I think it's easier as you expect. At first, you have to identify a key person in your area of interest. As an example, if you like to do an urine culture project in the urology, you have to identify the main interested physician in this team and then the main nurse who she is doing care for patients and so on. And then you have to discuss with them, what is the normal algorithm here to do urine diagnostics? Is there any standards, how to care for the patients and so on? And this is the start of qualitative research. And from my perspective, this is always needed because in each area it's totally different done and you have to include the perspective of the people. And the second point is you have to explain them early why it is important to do it. As an example, as I started my blood culture diagnostics, I explained to them, look, if you do it in a proper way, there is no need to do control diagnostics. So you will miss the time to do control blood culture diagnostics and so on, and have more time for other things. And this is the thing that people see. It's always, okay, it's less work for me. And the second point, it's better care for patients. That's normally always working. In all of my experience, you have to do it in this way. And then it's not so difficult to yeah, a kind of project with the final goal to implement it as a standard in this area. But it is not possible in the most cases to do it for a whole hospital. It's a bit like ESMİTA said, surgeons are different to the medicine team, and it's totally true. And I saw that in the medical faculty are different habitats for blood culture diagnostics also. In each ward, they do it in a different way. So you have to address step by step each of these areas. Yeah, it's hard, but it's possible.
Thank you very much. Sesin hocam. Okay, we will take your questions, Sesin hocam.
No, not a question. I'm sorry. It's we are overdue. So just a small addition. Maybe if you have a department of education in the clinics, you know, for blood culture, we are facing the same problem. So each department has to have a clinical education team. So we have to work. I'm an infectious diseases specialist, clinical microbiologist also, but with the microbiology lab, also together, we are taking cultures from the environment. So we are always in collaboration with each other. So medical education team has to be on the lookout for our collaboration. That's all I was going to say. Thank you. Thank you very much.
Thank you.
Thank you very much.
Teşekkürler. 5 dakikada geçtiğimiz için artık kapatıyoruz. Katılmanız için teşekkür ediyoruz herkese. bütün konuşmacılarımıza.
Teşekkür ederiz.